the time on this Friday to attend this webinar. If you could just quickly mute your lines. If you are not asking a question, we would really appreciate it. And I just want to give a quick introduction to Mark Blackley, who is President and CEO at Radiant Behavioral. He will be giving us a brief overview of his group today, and then he will also be introducing the LifeSpan platform, which is a tool that we can use for screening and referral. Mark, if you're ready, you can take it away.
Yes, I sure am, and you can hear me, right, Kelsey? Because I did have it muted, and I unmuted.
Yes, we can hear you.
Okay, great. Anyways, hello everyone. Good morning. It's morning here, at least on the West Coast, and I want to thank everybody for sitting in today, and Happy New Year to everyone. What you should be seeing on my screen is or on your screen rather, is the homepage of the Radiant corporate website, and I have this here just by way of introduction to give you a little bit of background on our company. We are a web development firm. We're located in Laguna Beach, California, and we specialize in building proprietary web platforms strictly in the behavioral health and well-being sectors. We've been doing this for about 16 or 17 years now, and during that time, we've been able to hone our platform architecture in such a way that we are now able to build quite a number of different products on top of the basic architecture that we have. So to give you an idea of what I'm talking about, I'm going to click on our products page here, and listed here are about a dozen or so platforms. We actually have more that we market to various groups and stakeholders. But this is just to give you an idea of the breadth of different products that we do offer and market. We got our start in developing and marketing a platform called Better Living into workplace populations, primarily through employee assistance programs. As you may be aware, employers are very keen on making sure that their employees are healthy, happy, and productive, and so they're always concerned about absenteeism and presenteeism in the workplace. And so we've developed a platform for workplace settings that is now, through our employee assistance clients, being utilized by more than 1 million employees across the country, kind of a who's who of different employer groups that have access to the Better Living platform. That soon led us to also doing quite a bit of screening tools for substance use, and has since led us to have quite a number of addiction treatment centers as client companies. And more recently, we've been, and when I say more recently, I'm talking in the past 3 years or so, we've been marketing a series of platforms to FQHCs, and these include the ones that I'm showing you here. The first one is our standalone social determinants of health platform. That allows you to screen patients very narrowly for social determinants of health. And then once you identify patients who have SDH factors, what it really does is it facilitates your being able to make e-referrals out into the community to third-party resource providers. And these providers can include homeless shelters, food banks, women's shelters, addiction treatment programs, even things like a job training program. And so, but as I say, that's very narrowly focused just on the SDH piece. Now, we also market a platform called Behavioral Health Checkup. So on that platform, in addition to being able to screen patients for social determinants of health, you can also screen patients for up to 15 different behavioral health conditions. And then our most comprehensive platform, the one that we're going to be taking a look at today, is our LifeSpan platform. And this platform not only allows you to screen patients for social determinants of health and all of the different BH conditions that I just referenced, but it also is built on an expert framework, so that if you would want to screen patients for alcohol and other substance use, you can do so using an expert methodology. So meaning that if patients were to screen at risk for alcohol or other substances, they then may be prompted through our web-based brief intervention. And if they're scoring in a range that indicates they are using substances at dependent levels, rather than taking them through the brief intervention, our database will essentially redirect them to our treatment locator, which consists of the SAMHSA database of over 13,000 treatment centers in the country. I'll talk a little bit more about this, but the other things that you can do with this platform is that if you're operating any sort of a MAT program, medically assisted treatment, we also have a module built in called Recovery Checkup that aligns perfectly with MAT patients, because as you're probably aware, it's not enough just to transition a patient from, say, opioid use to Suboxone and then call it a day. You really need to have a robust follow-up mechanism in place, and that's what the Recovery Checkup module allows you to do. The other thing you can do with the platform, which may be of interest to those of you who come from health systems or hospitals or even medical groups, is that we have a new screening tool that we built in called Aftercare Checkup, which is, it's kind of in its formative stages, and I'll share it with you, but it's a way for you to periodically follow up with patients who have recently been discharged from the hospital, and it could be used for any number of specialties. So say if somebody had hip surgery or hip replacement surgery, or even prostate surgery, breast cancer surgery, whatever it might be, you could use the Aftercare Checkup to check in with those patients periodically to understand how they're doing in their recovery. It could alert you to any potential issues that may be going on with the patient, but it's a way to stay in touch after they've been discharged, and potentially to gather some analytics around how you're doing in your different specialty lines of care that you offer in your hospital settings. So with that, I'm going to take us to this next screen, which is the patient-facing side of the LifeSpan platform. I suppose you could refer to this as a patient portal, although we don't really consider LifeSpan to be an EHR per se. It nevertheless can be integrated in with your EHR system, and we can certainly talk about that and different levels of EHR integration that can be achieved. But mainly what I want to share with you here are the different modules that are built into the platform. So this is a list of the different BH modules, and you'll see the three across the top are the alcohol module, the drug module, and the tobacco module. These are the three that are built on that SBIRT framework. So SBIRT being an acronym for screening, brief intervention, and referral to treatment. And I touched on this a little bit. We'll get into this in a little more detail as we go through. I'll even share with you what the brief intervention looks like as we go here. But in addition to those three substance use modules, you can also screen patients for things like gambling, depression, anxiety, sleep disorders, sex addiction, eating disorders, PTSD, both civilian and military versions, intimate partner violence, bipolar disorder, anger disorder, and panic disorder. So it really covers the waterfront in terms of the different BH conditions. What I would tell you about each of these modules is that each one has embedded into it a brief validated screening tool. So for example, with the depression module, of course, we're using the PHQ-9. For alcohol, we use the 10-item audit screener. For the drug one, we use the what's called the NIDA modified assist. For PTSD, we use the ones developed by the Veterans Administration. So they're very effective in their case finding capabilities, but also in rendering a severity score that lets you know just how challenged a patient may be by one or more of these BH conditions. Now, in addition to screening patients for these different BH challenges, you can also screen patients for social determinants of health. These SDH factors include things like, housing insecurity, food insecurity, income insecurity, transportation. There's a whole sort of standard list of items that our survey covers. But the reason that we feel this is important is because none of these things tend to happen in silos. You will typically find that a patient who may have co-occurring BH challenges also likely has multiple SDH factors, and one can contribute to the other and vice versa. So by also screening for the SDH factors, it really gives you a much more holistic snapshot of what all the patient may be challenged by. The other thing that we know about patients that have co-occurring BH challenges as well as SDH factors is that they tend to be the high-cost utilizers of healthcare services. They're the ones that show up at the ER most frequently, the ones that show up at either your clinics or your medical group practices more often. We also know that those patients have shorter lifespans. So being able to basically provide interventions around not only their BH challenges, but some of their SDH factors is extremely important, because these patients, we know, will drive the healthcare cost about 3 times what a regular patient does. And so these are your high cost utilizers, and they tend to be the ones that would undermine to some degree the cost saving goals of a patient-centered medical home model, for example. So, so again, the platform gives you the ability to screen, as I say, not only for the BH part of this, but for the SDH factors as well. And so what I'm going to do here next is I'm going to go to the administrative side of the LifeSpan platform. You'll notice this is very Spartan in design. That's intentional. It's really just designed to be a series of links that are very easy and intuitive for you to use. What I can tell you is that if you are able to operate an email program, you have enough skill set there to be able to operate and administer the LifeSpan platform. It's really that easy and user-friendly to use. The first thing I want to share with you here is what we refer to as a facilitated screening. But before I do, I'm just going to little sidebar here to tell you about the different screening options that you do have. Of course, you have what we refer to as the option to do a facilitated screening. And by that, I mean that you would have a staff member, it could be a counselor, whomever, actually sitting face-to-face with the patient, asking the screening questions of the patient, and then logging their responses for the patient. However, we only recommend that the facilitated approach, the face-to-face approach, be reserved for those patients who have language or literacy barriers. Otherwise, we would encourage you to allow patients to self-administer their screenings. And there are a couple options for how that can be achieved. One would be that you can hand the patient a tablet computer, either in the waiting room of a medical clinic, potentially before discharge out of a hospital, and allow them to do the screenings on their own. The second way that it can be done is that if, for example, you know that a patient is going to be coming in for a medical appointment, you could prompt the patient, say, a week in advance of their next office visit to complete the screenings online in their own time. Now, of course, this would require that those patients have internet access, but even if that access is only by means of a smartphone, you can still prompt them. Now, the prompts can be sent out via email, text message, and voice message reminders. You can also program it to send out multiple prompts over a period of days to ensure that the patient complies with the screening request. But the bottom line is, with regard to self-administered screenings, there are two really great benefits. The first being is that it takes a lot of burden off of staff to not have to be facilitating every screening. But secondly, and more importantly, is that all of the research in this area indicates that self-administered screenings actually yield much more reliable data than you get if you're doing a face-to-face facilitated screening. And the reasons for that are pretty simple. It's that patients can often feel intimidated or judged or even ashamed, particularly if you're asking sensitive questions around their substance use patterns or their SDH factors. So again, just to kind of underscore, we always encourage, whenever possible, for you to allow patients to self-administer their screenings. So with that, I'm going to go in here to the facilitated screening interface so you can just see how screenings can be conducted here. I'm going to pull up a mock patient account with my name on it just for purposes of our demo here. When I do, you'll see my name over here, and off to the far right is this wrench icon. I'm going to click on that. It gives me some options here, but I'm going to select the facilitated screening option. And when I do, it brings up two additional options. I can either do an assessment or I can do an individual module. I'm going to first click on the individual modules option so you can see here there are listed all 15 of those BH modules that I had shown you previously. So this is where you would go if you ever wanted to prompt a screening for, say, like a one-off screening for depression or anxiety or even intimate partner violence, whatever it might be. However, for the most part, our client companies use the assessments, and there are quite a number of assessments on here. There are a few that I would call your attention to. The first one is the aftercare checkup, which I mentioned at the outset. That allows you to periodically check in with patients who have been discharged from your facility. And again, we have one sort of generic aftercare checkup survey, but we are looking to partner up with some hospitals that might want to work with us around developing surveys that would be specific to different specialty lines. So again, orthopedics, whatever it might be, to come up with more specific type of surveys to do these follow-ups with. The second one, screening tool or assessment that I would call your attention to here is our BHRA. That stands for Behavioral Health Risk Assessment. That allows you to screen patients for up to all 15 of those BH conditions in one streamlined assessment. Now, typically, with like our clinic clients, they do a version called BHRA 5, where they're screening for the 5 most common BH conditions. That includes alcohol, drugs, tobacco, anxiety, and depression. However, we can configure it for you however you would like and add or subtract to that list. The one that I'm going to show you today here on the demo site is screening for the 8 most common BH conditions. So I'll show you that in a moment. But kind of moving on here, the other screening assessments that I mentioned that I think would be relevant for anybody that has a MAT program is the recovery checkup assessment. This allows you to periodically check in with those patients who are enrolled in your MAT program. It lets you know how they're progressing in their recovery. It also has some predictive qualities that would let you know if a patient may be headed for a relapse or if the patient has relapsed. And so it's a very important component to have with something like a MAT program. And then, of course, the last one I would highlight here for you is the Social Determinants of Health Survey, which we're going to touch on here. So just getting started, let me first share with you the BHRA, that's the Behavioral Health Risk Assessment. I'm going to pull this up, and you'll see here a series of pre-screen questions. These are all validated pre-screen questions, and what they're designed to do is to first of all, rule out those patients who do not have any BH challenges. So in other words, if you were to, for example, hand the patient a tablet computer and you ask them to complete this BHRA pre-screen, if they do not answer any of the questions here in the affirmative, then within about 3 to 4 minutes time, they are done, and it is assumed that they do not have any BH challenges, and hence they move on through your system. And they might be candidates to be rescreened in another 6 months to a year. However, if a patient does answer any of these questions in the affirmative, then they will be redirected to a fuller module to take a deeper dive. So just in terms of the questions themselves, I mentioned on this demo we're screening for 8 very common conditions, but you'll notice that the alcohol questions that are here are actually what are known as the Audit C questions. The drug question is the one developed by NIDA. The depression questions are the PHQ-2. The anxiety and panic questions come from the GAD. The PTSD one comes from the Veterans Administration. So they're very effective in terms of, just trying to ferret out and rule out those that don't have any BH challenges and potentially rule in those that do. So for purposes of our demo, I have this little automatic fill button here. This is just going to fill in the responses according to these red highlights. This button is only here on our demo site, but what it's going to do is it's going to answer the alcohol, the drug, and the depression pre-screen questions in the affirmative. So I'm going to go ahead and submit this, and when I do, you'll see that it has now triggered the alcohol module, the drug module, and the depression module. Now, I can go through any one of these, but I would recommend that we either go through the alcohol or drug module simply because I can then show you the SBIRT framework to this, which would include the brief intervention. So maybe I'll just go ahead and make a decision here, and I'll take us through the alcohol module to start. The first thing that comes up on the alcohol module is what is known as the standard drink chart. The reason this is here is because we are using the 10-item audit screener, and if you are familiar with that screening tool, it asks specific questions about how many drinks do you have during a day, how many drinks do you have during a week, and so forth. And what it's actually referring to is what is known as a standard drink. So to give you an idea of what this means, a standard drink is considered to be, for example, a 12-ounce can of beer, or a 5-ounce glass of wine, or a 1.5 ounce of 80 proof spirits. What these each have in common is that a 12-ounce can of beer, 5-ounce glass of wine, and a 1.5 ounces of 80 proof spirits all have the same amount of alcohol content. So each of those within those 3 categories constitutes a standard drink. The reason this is important is because sometimes people will drink something like a Long Island iced tea that might have 3 or 4 different types of alcohol in it. And though it's all in one glass and they think they're drinking one drink, in reality, they may be drinking 2 to 3 drinks. So once the patient understands what is meant by a standard drink, they click the Continue button, and this brings up the 10-item audit screener. This is the most widely used alcohol screening tool in the world. It was developed by the World Health Organization. It has about 35 to 40 years of evidence base behind it. And it's particularly well attuned to an SBIRT type of context, because what it does is it parses out the different drinking patterns and informs you as to what the appropriate intervention is depending upon how the patient answers this. So again, for purposes of our demo, I'm going to click on this automatic fill button. What it's going to do is fill it in according to these red highlights. That's going to ensure that we screen in an at-risk range, and that in turn will cause our database to prompt us through the brief intervention. So I'm going to click the Submit button, and when I do, you'll see that I've scored a 13. Anything between 8 to 15 on the 10-item audit screener is considered exceeding safe use guidelines. So it means that I'm drinking at risky levels. also, the way in which I answered triggered what is called the heavy or binge drinking alert. Heavy or binge drinking is considered to be 5 or more standard drinks for men, 4 or more standard drinks for women in any one day, and it's also considered to be 15 or more standard drinks for men, 8 or more standard drinks for women in any 1 week. Now, in the pyramid here, you see the normative data, and that's telling you that I've scored in the level 2 range, which is the risky range. About 9% of respondents to the audit screener worldwide will score in this risky range. About 8% will typically score in the harmful range, and about 5% will score in the dependent range. Now, just a word about brief intervention. Brief intervention is really only indicated and is really only effective with those patients who score in this risky range, as well as what is known as the low hazardous range. So in terms of score level, anybody scoring between an 8 to a 17 on the audit is considered to be a candidate for brief intervention. The logic being is that because their level of drinking has not gone to the dependency or high harmful stages, these individuals still have some decision-making capabilities and their wits about them, and they could actually make a decision to either moderate their drinking back down to normal levels or to quit altogether. So it's the brief intervention that is designed to help them make that decision. However, for those patients who score 18 and above on the audit, they are, strictly speaking, considered to be candidates for referral to treatment. So there is no reason for you to be wasting any time delivering brief intervention to those patients because it's of no value to them, it's not indicated, and instead what our database does is rather than redirect them to the brief intervention, it instead redirects them to our treatment locator. As I mentioned that at the outset, that consists of the SAMHSA database of over 13,000 treatment centers throughout the country. And because our database knows the zip code of the patient, it will present to the patient the 10 treatment centers in closest proximity to his or her zip code. Now, it's not that anybody expects that the patient is going to look at that and say, oh my gosh, I'm going to enroll in treatment, but rather it's designed to do 2 things. One, it's designed to essentially send a message to the patient that their drinking is at hazardous or dependent levels, and they are, in fact, candidates for referral to treatment. But moreover, it's designed to facilitate the add-on conversation that your interventionist should have with these patients to reiterate that they are drinking at very hazardous to dependent levels, that they are, in fact, candidates for referral to treatment, and to see if that individual interventionist can possibly help the patient to consider enrolling into a treatment program. Now, if you happen to be operating a MAT program, the idea here is to do a warm handoff of that patient to your MAT program so that maybe you could transition them from their alcohol use to something like Vivitrol and that sort of thing. So in any case, I just wanted you to be aware of when brief intervention is indicated and effective, and when it's not, and when somebody is a candidate for referral to treatment. So now down here at the bottom of the page in the red text, it's recommending to me that I complete the follow-up portion of the screening, which is really the brief intervention. So I'm going to go ahead and click on this. And when I do, this would begin the brief intervention. What this consists of are about a dozen interfaces. Woven through them are bits of motivational interviewing, some change talk, some solution-focused and CBT-type strategies. Again, all designed to get the patient to think about possibly making a lifestyle change, a behavioral change around their drinking. And that could include either moderating their drinking back down to safer levels, or it could include quitting drinking altogether. So what I would tell you about this brief intervention, first of all, is that it was developed for us by our partners. We are actually the technology partner for a group out of Washington, D.C. called the Brief Intervention Group. That is headed up by Drs. Eric Goplerud and Tracy McPherson. They are nationally recognized experts in SBIRT, so you can rest assured that what you see in the interfaces here basically contains all of the latest research. So even if a patient is doing the brief intervention on their own in a self-administered fashion, it is still very effective. Also, what this will do for you is if you end up having to do, a staff member has to do a facilitated brief intervention face-to-face with the patient, they have the luxury of being able to just follow right along with the brief intervention interfaces. So consequently, your staff does not have to be formally trained in brief intervention or motivational interviewing. So long as they can follow right along with the brief intervention interfaces, they can end up delivering a very effective and standardized brief intervention every time out. Now, if you did not have the benefit of these brief intervention interfaces, you have to have staff formally trained, and there's a lot of variability in the efficacy when you're doing brief intervention in a more extemporaneous fashion without the benefit of these interfaces, and that is because so much depends on the skill set of the interventionist. So, and frankly, you know, some people are better at it than others. Also, if you have people that leave your employee that have been trained in brief intervention, you now have to continually have new staff getting retrained. So it eliminates all of that. Eliminates the variability that you get dependent upon the skill set of the interventionist. And furthermore, we have noticed that with our brief intervention, it takes about 8 to 10 minutes to get through it, whereas if you're doing it more extemporaneously and not being able to follow along with the brief intervention interfaces, the intervention tends to take longer. It can take up to 15 to 20 minutes. And so if you're in some sort of a clinic setting where, you know, time is sort of crunched, it makes it difficult to get through some of these brief interventions and takes up a lot of staff time and energy. So I just wanted you to be aware of this. Now, what we can do here, if you like, is I can take you through the brief intervention. It'll take about 8 to 10 minutes to get through it. Or if you prefer, in the interest of time, I can go in and pull up a prior patient record where we did a brief intervention and just show you what the responses look like. So I'm just going to ask maybe Kelsey to weigh in on this, or any of you, for that matter. You can unmute and let me know if you want me to take you through the brief intervention. And also now might be a good time just to pause for a moment and see if you have any questions up to this point. So anybody, feel free, unmute, and let me know, first of all, what you want to do, if you want to go through the brief intervention or have me show you a prior one.
Thank you, Mark. I think a patient record would be really interesting.
Okay. So yeah,
I would go for that. Yeah.
Okay. So we'll do that. Does anybody have any questions about what we've discussed up to this point? Feel free. Don't be shy.
This is a question I have. I mean, this is really good. I'm really interested in looking at here. Do you have any client organizations that are able to import this data into their EHR?
So there are different levels of integration that can be achieved. The one that is typically the most cost-effective when we're talking about, small FQHC clinics that are, don't have a lot of money to spend on these types of integration things. We do a browser-based integration whereby we provide their vendor with a series of links that are the most common areas on our platform that you need to access. Their vendor installs those links, and they effectively appear on each patient chart. And so if you were in a patient chart and you needed to see, for example, how that patient had screened on any number of screening tools, you simply click on a link. What it does is it opens a new browser, hence the name browser-based integration, and it redirects your request directly to the page on our platform where that information resides. So it's really just a very seamless one click and you're there type of thing. so that is what we refer to as a pull integration, where we're pulling certain demographic data about the patient, including the patient ID, which helps us to route that request to the area on our platform where that patient's data resides. So we're pulling data. What you were asking about is, can we push data back to the EHR? We can certainly do that, but therein, I think, lies a lot more expense in terms of, one, the vendor has to basically build a facility to accept the data securely and then be able to format that data into interfaces that look somewhat similar to our platform. So in my experience with the large vendors, doing an integration like that can be time consuming, it can be costly, and not to mention it can take quite a while just to get it on their development calendar. That said, we don't charge anything on our end to do the integration work, because frankly, most of the work ends up being done on the vendor side. But we stand ready to do any type of integration that your vendor is willing to work with us on, and one, hopefully that they don't charge you too much money to do.
So do you have any client organizations that have a large EMR company like Epic or Cerner or Athena that's currently pulling data from the system?
Yeah, so we have, as an example, Athena. The reason we like working with Athena is they have their own API that they provide to us. They're kind of user-friendly to other third-party vendors, which is it's kind of more of an open source approach. And so, yeah, we use their API. We pull certain demographic data through their API, including patient ID. We can also pull your login credentials so that if you're in your Athena interface and you want to access our platform, you can click on a link and it takes you right into our platform. You don't have to actually log in. So it's like a single sign-on, because it's bringing your login credentials over. It's bringing the patient ID so we can route the call where it needs to go. And then if you need to register a patient onto our platform, we pull a lot of the demographic data, like the patient's name, of course, and maybe last 4 digits of social security number, mother's maiden name, gender, age, those types of things, so that all of that data pre-populates our registration fields so that you don't have to go back and reinvent the wheel. It'll all be there pre-populated for you, and you can pretty much register a patient very easily without, like I say, having to fill all those fields in. So yeah, and then if the vendor does not have an API that they make available, we have our own APIs that we can ask them to install.
Okay, great,
okay.
Thank you.
Yeah, anybody else, any questions before we push on here? Okay, so what we're going to do, I think we all agreed that we are going to, rather than go through the brief intervention, I'm going to pull up a prior patient record mock account. So I'm going to go to this link. It's called Screening Data Bin. And a little bit about this before I do. Anytime a patient does any screening on the platform, and if they screen at risk for anything, it causes their patient record to be deposited into this screening data bin. And at the same time, our database kicks emails out to each staff member who has created their administrative account on the platform. That lets them know that screening data has been received, and that prompts them to log in and retrieve the data. And this is where they would go to retrieve it. You click on this screening data bin, and it brings up all of the recent patient activity, and then you can go in and select the patient and view their screening data. So as an example here, this was one where we did the brief intervention. I'll show this to you. On the brief intervention, what we do is we have the entire screening summary for the alcohol audit screener. So here again, you'll see my score of 13 on the audit, the heavy binge drinking alert, the normative data in the pyramid, but most importantly, you see all of my brief intervention responses. Now, what this does for your interventionist is that it acts like a roadmap to let the interventionist know how best to engage with the patient around whatever their goal may be. Now, in this case, I'm indicating that I would like to cut back on my drinking. And so in the process of going through the brief intervention, I was asked to basically come up with strategies that might work for me in terms of cutting back on my drinking. I've been able to identify intrinsic motivators that might help me to cut back on my drinking. Even indicates what my readiness to change is over the next 30 to 60 days, even what barriers I perceive I may encounter when I want to try to cut back on my drinking, and just how important this change is. So again, what this will do is allow the interventionist to sort of revisit all of the screening data, the brief intervention responses with the patient, and sort of reaffirm for the patient what the patient, him or herself, has identified as the most effective route toward making this particular change. So again, it's in that motivational interviewing style of meeting the patient right where they are, not trying to dictate to the patient what you think they need to do, but rather the patient basically showing you the things that would work most effectively with them. And so, like I say, this is really going to sort of turbocharge the intervention, the follow-on intervention that you have with the patient, to sort of review their brief intervention responses and sort of double the effectiveness of it in terms of helping them to make whatever change they've identified here. So that's to give you an idea then of how the brief intervention piece works. A couple other things I want to share with you real quick, and then we'll try to open it up for questions. I'm going to go back into the facilitated screening, and I'm going to pull up that same patient chart that I had. Gradient 551, I believe is what it was. And go back into the facilitated screening. Again, assessments. And I'd just be curious to get some feedback real quick on this aftercare checkup. This, again, is something that's in the early stages here, but I'm going to pull this up so you can see it. It's just a very brief survey that asks the patient how they're doing. This could be used generically across different specialty lines, I suppose, but the idea here would be to try and tailor make quite a number of these for each specialty, and maybe even specific procedures that they may have done in the hospital. And the idea is to be able to either facilitate this as a screening. It can be done by phone or by secure video chat conferencing, but it can also be prompted remotely. So, and it could be set up on a schedule so that maybe you check in with them at 2 weeks post-discharge, and then 4 weeks, 6 weeks, whatever it might be. So we can give you the ability to do that. But I just wanted you to be aware of that. Be curious to get some feedback from you on that. The other thing I wanted to share with you, very importantly, is the social determinants of health piece, because that is a huge piece to all of this. And so you'll see on our social determinants of health survey, it consists of about 16 items. The first thing we're asking about is employment status. We know that patients who are unemployed or underemployed are going to struggle. We also know that patients with less than a 9th grade education tend to struggle. We ask what financial assistance they may be receiving currently. We ask if they are experiencing any income insecurity that necessary to meet their basic needs for things like housing, utilities, and food, transportation, etc. We ask if they ever experience any food insecurity, whether they feel they have access to adequate medical or healthcare services. We ask what their specific housing situation is today. Do they ever have problems getting child care that make it difficult for them to work or study? Are they ever exposed to polluted air, polluted drinking water, or environmental toxins? I often think of Flint, Michigan with their water problems there. Ask them to describe the safety of their neighborhood, whether they have family members, friends, or a broader network that they can rely upon for support. Do they have access to transportation? Do they ever feel discriminated against? Do they ever experience verbal, physical, or sexual abuse of any kind? And this can be in the living environment or the workplace. Very importantly, do they fear deportation that is keeping them from seeking health or other social care services? And then the last question here is kind of along the lines of the adverse childhood experiences or childhood trauma. And then down at the very bottom, we ask them to specifically indicate which of these items they need help with, because what we found early on in doing this survey is that a lot of patients will end up answering a lot of these in the affirmative. However, they don't always feel that they need help with some of these items. So it's really a way for you to be able to triage for your interventionists to know which items are the action items that the patient needs help with the most. So I'm going to go ahead and use our trusty automatic fill button again to fill all this in. I'm going to go down here and submit it. And when I do, it's going to provide your interventionist with a list of the different SDH factors that the patient has self-identified, including any childhood traumas, but most importantly, it's going to indicate which items the patient feels he or she needs help with the most. And so these are your action items. And these are the items typically that are, while some of them may require, some a meeting or intervention or counseling with one of your BH counselors, more than likely, a lot of these SDH factors are going to require that you make referral out into the community to third-party resource providers, as I mentioned, your homeless shelters, food banks, women's shelters, whatever it might be. And so what I wanted to share with you next is how easy it is for you to make an e-referral out in the community. So again, I'm going to go into the screening data bin. I'm going to go down to the very bottom here, which has the most recent screener or most recent account that we set up here. I'm going to go into the wrench icon and I'm going to select the refer option. And when I do, it's going to bring up a list of your internal counselors or coaches who have created their accounts on the patient-facing side of the platform. So in this case, we have a mock account for Dr. Sigmund Freud, assuming he's an internal counselor. And I'm just going to type in an instruction to him that says test. And then you can also, as I mentioned, onboard as many third-party resource providers onto the platform as you like. And these can include things like addiction treatment centers, food banks, homeless shelters. Let's make a referral here to a job training program. Again, I can send an instruction to this person. I can also allow this person to provide progress notes back to the file so that everybody can see them and be able to know just how the patient is doing, but it also builds in this accountability so that we're certain that no patients are falling through the cracks. And so with a couple of mouse clicks then, I'm ready to submit. And now what's happened is our database has sent emails out to each of those individuals, to Dr. Freud and to the job training program guy, lets them know that they have a referral pending. That prompts them to log in, retrieve the referral, and then follow up with the patient. Now, to give you an idea how that works, I'm just going to go real quick. I'm logged in here under the Dr. Freud account. You'll see it says this client referrals inbox. I'm going to go ahead and click on this to refresh it, and you'll see there's one new one in there. And so this is the referral we just sent. Dr. Freud can go in and see all of the patient's screening data, can drill down on that data if need be. Can see, for example, how the patient answered the BHRA pre-screen. And then Dr. Freud can also view any instructions from admin. We just typed in test there. And he can either accept or decline the referral. I'm going to go ahead and accept the referral. And when I do, it's going to move this patient into Dr. Freud's patient roster. And from here, Dr. Freud can manage all aspects of this patient account, can be accountable for his own roster of patients. He can do various things like adding progress notes, can view progress notes, including any progress notes provided by the third-party jobs training program, as an example. He can also do some screening with the patient on his own if he likes. He can also potentially refer individuals back to you, which we'll talk about in a little bit. but he could also potentially conduct a secure video chat conference if that was something you would ever need. So basically, that's just a way of showing you how easy it is to make the e-referrals and to build in that accountability so that no patients are falling through the cracks. And as I mentioned, you can onboard as many third-party resource providers as you like. There's no additional charge to do that. And it's a way for you to sort of expand the services that you provide beyond the walls of your hospital or your clinic or your medical practice, whatever it might be. And so lastly, I'm going to wrap up here. I'm going to share with you a couple of other things real quick. Let me see if I can get back over here. A couple things I want to show you is, first of all, the screening analytics. Our database is tracking every single screening in real time that gets done on the platform, and it can give you a distribution across your entire patient population by condition type. So for example, you could see how many patients screened for alcohol, how many screened at risk, how many were delivered brief interventions, and so forth. You can parse this data or filter it by date range. So if you just wanted to see for this week how many had screened and that sort of thing. You can also parse it by location. So if you have more than one hospital, or you have more than one medical group, or any number of different specialties, we can create subdomains for each of those, and you're able to track it and filter it by just specific locations or specific specialties. You can always, of course, print this. You can also export it to PDF. We can give you the ability to also export it out to like an Excel or a CSV type file if that were needed, but you can use it for appending to, you know, any sort of reporting you may have to do and that sort of thing. The other thing I wanted to share with you is the extensive amount of analytics we do around social determinants. So we take each of the 16 items within the SDH survey. We indicate each possible response, and then across your entire patient population, it'll show you the distribution of the responses across all 16 of these items. And then down at the very bottom, it will tell you which items the patients have identified as being the items that they need help with the most. And so this helps to inform you as to which third-party resource providers you need to be cultivating relationships out in the community with to sort of provide intervention and services to these patients as they're indicating what's the most needed among them. So again, you can filter this by date range, by specialty type, clinic location, whatever it might be, and you have the same export features as the other analytics page. So with that, I'm just going to stop for a moment and ask you guys if you want to open up your, unmute your phones and see if there are any questions I can answer for you.
Thanks so much, Mark. This is Susan, and really appreciate I feel like the hour kind of flew by just in terms of, you know, just showing us kind of all of the various really just very interesting components of the Lifespan platform. So just realizing, because I think a couple folks have already expressed this, I know that there are some folks who have questions about kind of the cost and things like that, and just to kind of let folks know, you know, we've already talked to Mark about that, and I think a lot of that is really dependent upon a number of factors, including kind of volume and things like that. So that's not something that we can give a quick and easy answer to. So I just wanted to, you know, kind of forestall any of those questions at this point. But, you know, if there's interest, we can certainly do some more like targeted follow-up around that. So Mark, I just wanted to save you a little bit from that piece right now. But I think, yes, I'm just going to go ahead and let anyone in the last remaining moments have, if they have any other questions beyond that, please feel free to chime in.
Yeah, and by the way, I'm happy to do another demo for any of you who may have, you know, other management or other of your colleagues that might want to see the platform. I'm happy to set up individual demos for each of you if you need that. So. But anyways, if you have any questions, feel free to ask, and we'll do my best to answer. Anybody? Okay, well, it sounds like I did a good job. Nobody's asking any questions. So,
well, Mark, if I may, I just was curious about, just because I think this is, a lot of this actually kind of intersects with a lot of other related work that's sort of happening in this space, particularly as it relates to the social determinants kinds of issues. But just very curious about, in terms of the databases that are being used. So, for example, say the treatment referral ones, like how quickly and how frequently do those get updated? And is it just really reliant on kind of the SAMHSA source? Just a little bit more about the database updating capability would be helpful.
Oh, so, well, we have the SAMHSA database of treatment centers, which, you know, we periodically update because it's not something that they push updates out to us, so we have to go in and manually do that. But that's less of a concern because we really see the treatment locator as being more of a messaging device than anything else. It almost doesn't matter that because typically nobody's going to, you know, go enroll themselves in treatment based on the treatment locator. It's really, like I say, a messaging device. But in terms of, you know, any updates that, you know, if any of the screeners change and we become aware of those things, we update any changes that may occur to the screeners, although most of these are tried and true and been around forever, and there aren't a lot of changes that come down the pike on a lot of these at this point. And then was there something else here? Oh, were you asking about the database of third-party resource providers?
That too, yeah. So it's all.
So we do not ourselves maintain a database or a directory. Where especially the grant agencies and you know, NIH and all these different organizations are trying to get you to go with this is they want you to cultivate personal relationships out in the community with these third-party resource providers. They prefer to be people that you know and can depend upon, because right now what happens in a lot of clinic settings is that they'll screen a patient, find out he has some SDH factors, and then they'll print something off the internet, hand it to the patient, and hope that the patient makes it across town to go to this place. Whereas with this system, it really encourages you to forge a relationship out in the community, ask the person that is the point person for that organization to create their own profile on the platform. And then when you make referral out to them, you have a personal relationship with them that you know you can depend on them to follow up with the referrals when they get them. So again, we aren't maintaining any directory. It's really on the clinic or the hospital or system, whatever it might be, to have an outreach person that can go out and forge those relationships in the community.
Okay, great. Thanks so much, Mark.
I have a quick question. Sorry.
Sure.
Go ahead.
Yeah, go ahead.
Just in terms of language, the various scales like the audit, the PHQ-2, PHQ-9, do you have them available in Spanish or any other language?
Yeah, I'm glad you asked that. We are actually in the throes right now of installing a language translation API, and it's actually a Microsoft product that supports 50 languages. The first ones that we're going to activate are Spanish, Russian, and Portuguese. Those are the Spanish, clearly. The Russian and Portuguese kind of threw me a little bit, but those are the ones that thus far have been requested of us.
Okay. And the other thing, the question I had, when you were going through the social determinants questionnaire, just one thing that kind of struck me was wondering at what reading level you structured these questions.
Sure.
I know there's a lot of talk in healthcare about how we often use language, you know, in written material that many times is beyond the reading level of our average, you know, consumer.
Right. Yeah, so we've sort of had our stuff reviewed, and pretty much what they came away with was you have to be able to read at a 9th grade level to basically understand everything that's on the platform and the different questions. So that said, it kind of gets to language and literacy barriers, as I was talking about previously. if you have a patient that is struggling with that, and unfortunately they don't often tell you that they are struggling with that,
Right.
they would be more of a candidate for a facilitated screening face-to-face as opposed to allowing them to self-administer. But again, that's one of those sensitive questions where you might ask somebody, you know, what's your literacy level here, and they might be ashamed to tell you that they're struggling. So that can be a challenge.
Mark, this is Bridget. And this is also, can you customize some of the modules or shorten questions? Is there an ability to do that on this platform?
So we can take any screening tool that's in the public domain that you would want us to install onto the platform. We're happy to do that. What we can't do is if you have a validated screening tool, like the PHQ-9 as an example, we can't knock off 2 questions. I mean, it would completely invalidate the tool. So anything that's already has validation behind it, you know, you can't change it. It just wouldn't be psychometrically prudent to do that. But that said, if you have other screening tools that you want us to embed, we're happy to do that. And also understand too that not everything that you do in a screener has to be a validated tool. You can ask questions in a screening tool that are just designed for case finding. They don't have to be necessarily rendering a severity score. And in fact, a lot of what you see in the social determinants of health, none of the SDH surveys that are out there, including ours, have any real validation per se behind them, and none of them are designed to render a severity score. It's just not really, it's not really the purpose of it. What it's really designed to do is just do case finding to find out what people are self-identifying as issues for them. So, so the long story short is, yeah, we can install whatever you like if it's in the public domain. We can also take any sort of surveys or screening tools that you have maybe mashed together or created on your own. We're happy to do that as well.
Thank you.
Anybody else?
So, I think there may likely be lots of questions again as people are thinking more about all the things that folks have asked, and also the things that you've shared, Mark. So we actually will have a great opportunity next week at a meeting to be able to solicit any more questions. And just in the interest of time, since we are over, I think it probably is good to just sort of close, and just for folks on the line, just to say, you know, we will kind of explore a little bit more, because I think the things that will be important if folks are interested in pursuing this, in addition to cost, is sort of like some of the information security, data security elements to this. So just so you know that we're aware that this is something that we would be helping you explore further as a next step. So, yeah. Any final words?
Let's go ahead. What's that?
Oh, I just said, any last final thoughts or words you wanted to share with us?
No, I just want to thank everybody for sitting in on the demo. Just keep in mind that if any of you need a separate demo for your organization, we're happy to do that. And, you know, maybe some more questions will come forward after you guys have your next partner meeting or whatever it is next week. So anyways, we'll wrap it up. Hope everybody has a great weekend, and thank you so much for sitting in today.
Great.
Thank
you
you so much, Mark.
Great.
And
Bye-bye.
thanks to everyone who's joined. Have a great rest of your day. Enjoy your weekend.
Thanks. You too.
Bye.
Bye-bye.